Let's continue with our class. So we had etiology, we studied up to here, etiology, and then we were going for the symptoms of oral cancer, which were okay, the symptoms of oral cancer were a sore on your lip or mouth that doesn't heal, a sore. And then we studied, we said that we know about two sores related to HPV, and then it was candida or aphthous ulcer, canker sores and cold sores, and then we had a mass or growth in your mouth, any lump, and then bleeding from your mouth because of the involvement of vessels, and then loose teeth, pain or difficulty swallowing, lower lip, face, neck or chin numbness, and dramatic weight loss, and earache that won't go away, a lump in your neck, trouble wearing dentures, or say white patches and red patches in your mouth or lips, erythro and leukoplakia, jaw pain or stiffness, and reduction on the opening of mouth, angle of mouth, and then tongue pain or tooth pain or mouth pain. Okay, these are some of the common symptoms of oral cancer. You should know, and if you don't know, then you just try to make understand what can go wrong in that place. If you don't know signs and symptoms, then you can associate the clinical picture and see what can go wrong. If we are talking about oral cancers, then there can be a mass found in the oral cavity, and that can cause pain, it can cause bleeding problems, it can cause ulcers, and it can cause teeth to lose, and of course there is drum, and other than that, generalized, there is weight loss. So, and there can be lymph adenopathy, local lymph adenopathy, especially cervical lymph nodes, and then that's how you go. Okay, clinical features continued. Then we have cervical lymph node enlargement, especially if hardness is present in a lymph node or fixation. So cervical lymph nodes, the lymph nodes in a cervical area are enlarged. There is lymph adenopathy, especially if they are hard. If the lymph node is fixed, it's not movable, it's fixed to the underlying skin. You know about the features, how to evaluate swelling, right? One of the feature is to see the texture, rough or smooth, hard or fluctuating soft, fluid containing or not. And then you see, is it fixed to the underlying skin or is movable? And then you perform some test, torch test, and that, right, to see the fluid and that. And then about the cervical lymph node enlargement, lymph adenopathy, we can see enlarged nodes in a patient with oral cancer may be caused by infection, reactive hyperplasia secondary to tumor, or metastatic disease. So in the case of oral cancer patients, if there is infection or reactive hyperplasia, number of cells are increased, overgrowth as a secondary response to tumor, because you know tumor cells, they aggressively divide and reproduce. They divide, and then become an irregular mass of lump. So there will be hyperplasia, more number of cells, not the size. Number is increased, number plasia is increased, and then occasionally a lymph node is detected in the absence of an obvious primary tumor. So you have seen lymph adenopathy and there is no secondary feature, no other features, and then you take the biopsy of that lymph node because it is odd, it's a strange finding, and then biopsy or FNAC. What is FNAC? Fine needle aspiration cytology. You go for cytology and you find that there are some metastatic malignant cells in that lymph node, and then you can diagnose some of the oral cancers, especially squamous cell carcinoma, invasive to the lymph nodes, local lymph nodes. Okay, then second point, the most common site of OSCC, oral squamous cell carcinoma, include the tongue, especially the lateral side of the tongue and ventrolateral side aspect, and the floor of the mouth. Hard palate, lateral aspect of the tongue, then floor of the mouth, and buccal mucosa. These four are the topmost areas for oral cavity cancer. Then the lesions. What are lesions? Erosions of mucous membrane. Lesions always must be palpated after inspection to detect induration and fixation to the deeper tissues. So the lesion must be palpated, of course, with the gloves, surgical gloves, for after inspections to see if there is indurated or rough edges, and then you can see the roughness or smoothness of that, and then fix if it's fixed or hard and fixed to the deeper tissue. A typical malignant ulcer is hard and heaped up and often everted or rolled edges. So a typical ulcer which is malignant is hard on touch, is heaped up because of the overgrowth of cells, is heaped up, hyperplastic, and often everted. So ulcer, the edges are everted and or rolled edges. So it's rolled edges or everted, hyperplastic, yeah, or rolled edges, and a granular floor. So the floor is granular to touch, or some maybe some. Let's just do some whitish to distinguish. So the floor is granular. Okay, and then we go towards the next. Most cancer, oral cancer, arise in the anterior floor of the mouth as an indurated mass that soon ulcerates. So the mass appears and it will usually after within 3 weeks it ulcerate and resulting in the slurring of speech. Slurring of speech. Yes. Okay. Slurring of speech. Remember, carcinomas of the alveolus or gingiva can present as an exophytic mass or a persistent. Okay. 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 Thank you, Tahir. So most cancer arise in the anterior floor with done. Carcinomas of alveolus. What is alveolus? This is talking about alveolar bone, socket of the teeth, or gingiva, or gums can present as exophytic mass or a persistent ulcer. So there will be exophytic mass extruding outside and coming outside is like blooming outside, and then is a persistent ulcer. It's not healed, it's not healing, it's persistent ulcer. And then the underlying alveolar bone is invaded in 50% of the cases. So as you remember, there was also weakening of bone, and the bone matter was seen of rate changes. Even if you don't see any change in X-ray, yeah, still there can be invasion in 50% cases of oral cancer, oral squamous cell carcinoma. And adjacent teeth may be loose. Why loose? Because the bone matter, the bone tissue is weakened and less. So the tissue cannot hold in the socket is weak. The teeth will be loose. What do you mean by loose teeth? Easily movable, yeah, mobile, not fixated, not fixed in a place. Okay, so self-examination is easy and could save your life. What do you mean by self-examination? You examine by yourself. You look for ulcers, you look for patches, you look for lumps. As you know, ulcers, there were many ulcers we studied, right? Oral ulcers. Remember, there were multiple, acute and chronic, and there were recurrent ulcers, aphthous ulcers, Behçet's disease, yeah, recurrent HSV, and then ulcers which do not heal within 3 weeks is one of the sign or symptom if the patient is telling. Patches. What patches? Red, lithoplakic, white, leukoplakic patches in your mouth. And then lumps, unusual lumps or swelling in your mouth. Unusual growth of tumors in your mouth. These are the common symptoms you can self-examine and see and save your life. So oral cancer on the right, oral cancer symptoms, for example, loose tooth, red and white patches, throat leukoplakia, and then tongue pain and mouth sores, canker sores and cold sores are some of the common symptoms for oral cancer. And now we talk about the mets. Whenever we are studying about the cancer, two things or three things are most commonly asked. Metastasis, where it does metastasize. Maybe initially it is asymptomatic, mainly it is asymptomatic, but it metastasized to another place and the symptoms of this place is appeared, but actually is the secondary tumor, primary tumor of oral cancer. So they ask you the mets. The second thing they ask you, and especially important for general surgeon, is T&M, staging of the cancer. So if you are going to evaluate or examine or inspect a lesion of oral cavity or oral cancer, you should know T, N, and M. What do you mean by T and M? T is the tumor size, T for tumor size, the size usually. Is it big, is small, what is the stage? And then if it's gone to the lymph nodes, N, and if it is metastasized or not. And according to T&M staging, we decide the regime. So the third thing is regime, treatment plan. So three things they ask you: meds, T&M staging, and then grouping, and then finally treatment regime. They ask you whenever there is cancer. And for general surgeons or surgeons, you remove the cancer, but you still have to give the therapy because a lot of hospitals do not have cancer center. So general surgeons or the surgeons are usually responsible for giving the cancerous medication or radiotherapy, chemotherapy, especially chemotherapy. So you should know these who want to be surgeons. Okay, clinical features, metastasis, lymph node examination, general examination, and endoscopy. Why general examination? Because we are talking about the local lesion, oral lesion, intra and extra oral examination will tell us the tumor size. And then N, T, N, M, N, lymph node examination is required, especially deep cervical lymph node. If it is metastasized, is lymphadenopathy found or not? And then endoscopy, because we need to see it visually, if it has gone down or it's oropharyngeal or oropharyngeal isthmus, that area is involved, or posterior tongue is involved. So we need some endoscopy. May be indicated to detect metastasis or secondary primary tumors. So, for example, it's to the anterior of the tongue and spread to the whole of the backside. That's why we need to know if tumors secondary to primary. From 30 to 80% of patients with oral cancer have mets. So oral cancer. So 3 to 8 people out of 10 people, if you have 10 cases of oral cancer, 3 to 8 people will develop mets, especially in cervical lymph nodes at presentation. Why at presentation? They already have some mets. Why? Anyone? At presentation, at clinical presentation, 30 to 80% with metastasis. Why at presentation? So if they have mets, isn't it too late? Because initially it is asymptomatic. Remember, it was initially asymptomatic, and then when they present, it's already late. So late that we have mets, we have metastasis. And then later dissemination. What do you mean by dissemination? Is also metastasis or dissemination, or the malignant cells move to the lungs, liver, or bones. So metastasis is towards the lungs, liver, and bones. LLB. Okay, oral cancer progression. Liver is involved in every metastasis. Why? because if it goes into the blood, if it go, there are two ways to for the metastasis. There are two ways for the metastasis to occur. One is through blood, and second is through lymph. One is through blood, and second is through lymph. So blood, all over the blood goes through liver, and it also goes through stomach, but it circulation, and then liver detoxify blood and a lot of things. So liver is almost in every case, in every cancer, the mets can be found in liver. And then lungs. Why lungs? Because we are talking about the oral cavity cancer. So the you can see the oral cavity is involved, and then meds can go directly inhale to the lungs. Yeah, or it can go again with the blood pathway or lymphatic pathway. Okay. And bones, because when it becomes invasive all the way through the muscles, then the bones can be involved. When muscles involved, usually there is less chances of muscle sarcolemas, or you know, you say muscle cancers, but bone cancers, osteomas, yes, they are more common in these cases. So secondary cancers, secondary to primary, are usually found in lungs, liver, and bones. But liver, we will find a lot of the secondary tumors growing in the liver. So on the right side, we have normal mucosa changing into precancer, dysplastic, and then invasive cancer. This is the oral cancer progression. And then we have altered cell. When the cells altered and we cannot differentiate, then this dysplastic are undifferentiated. We cannot differentiate them, that either they are the true or the false, or if they are the true cells of the area, or they cannot be distinguished. Either they are columnar, squamous, or cuboidal, or stratified, or non-stratified, or keratinized, non-keratinized. When they are not distinguished, cannot be differentiated, then they become dysplasia. And then finally invasive cancer. When it becomes invasive cancer, when it leaves CIS, when it leaves the area. What is CIS? Carcinoma in situ. And when it leaves carcinoma in situ, when it invades the basement membrane, it goes beyond the basement membrane, it becomes invasive. Okay. Other than that, we have genetic events, we have epigenetic events, and risk factors. What are genetic events? For example, point mutations. You know, point mutation, for example, there are mRNA or DNA. DNA is opened, and when mRNA is becoming, and then in one point there is mutation, and then, for example, you have ATT, and then you have AUU in the mRNA, and then what happens is this T becomes A, and then you will have here UAA, and then here you will be UUA, and then this is in one point there is mutation, this change in the nucleotide, and then point mutation can lead to oral cancers. Translocation is when we have mRNA or DNA and the whole codon translocate to another place. Translocation. Deletion is when one of it deletes, and whenever one of it deletes, so the codon will become this. And initially, if it was A U G, and now it is A U, no G, then this codon will code for another tRNA, another amino acid, and the whole protein structure will be destroyed. Yeah, I hope you remember. If you don't remember, copy number variation. This is also known as when the DNA is not properly replicated, and then we have some syndromes like Down syndrome. Yeah, copy numbers variation. And then gene amplification, when you enhance some gene, and then it can give the negative effect, genetic So a genetic event can occur and it can cause oral cancer. Epigenetic, when you try to methyl DNA or demethyl DNA, and then it can also be there. Histone modification. What is histone? This is a protein where DNA chain is bound, after every, let me try it. So you have DNA coils around histone, coils around histone. When the DNA is packing, it coils around the histone protein. That's histone modification. When the modification is epigenetic events. And then mitochondrial RNAs. What are the risk factors? Of course, lifestyle, tobacco, alcohol are the top post, and then HPV and pollution. Pollution can also lead to oral cavity because you will not take care of your oral hygiene. And then we have laboratory workup. So how we do the lab work for the oral squamous cell carcinoma, OSCC. To confirm the diagnosis of oral squamous cell carcinoma, a tissue biopsy must be performed to allow histopathological examination. So you take history and physical examination, and then you see, okay, this is a tumor or a lump which needs investigation. You go for biopsy, and then biopsy. After that biopsy, you go for imaging or histopathological imaging, and then you see there is a lesion, is beyond the boundaries, is invasive, and then you integrate your all the knowledge, and you find it is oral squamous cell carcinoma, and then you do a clinical staging for it, because you need to start chemotherapy and radiotherapy. Chemo and radios, then you need the clinical staging, because for different staging of TNM, there is different grouping, and different grouping will have different regimes of chemotherapy and different amount of exposure of radiation. And then you go for the treatment, you develop a treatment plan, and then you do pathological staging, and then you'll see the progression, and then you'll see if it is required adjunctive treatment or not. Okay, you see the mutations, because some clinical staging of the pathological staging have some mutation, and then mutation will lead you to the addition of adjunctive treatment. And then further investigations can be performed to look for the following. What are the following? To look for the primary tumors and to look for the metastasis. We need to look so that we can devise a treatment plan. Primary tumors typically located in upper air digestive tract, for example, mouth, nares or nares, pharynx, larynx, and esophagus. So these are the places where you can find the primary tumors of oral cavity. And for METs, for metastasis, for malignancies which have gone to other places, metastasis, METs. For METs, we can initially occur in regional lymph nodes. For example, in the case here, cervical lymph nodes, and later, initially in the regional lymph nodes, and later in the liver, bones, and lungs. Forget that. Very less chance. It has to part, because why brain? Because it's near to the cervical lymph node, and cervical lymph node, internal jugular vein, and then you see internal artery, cervical artery, and then you got brain. Imaging studies may help detect abnormalities missed during the clinical examination. So imaging studies can help in some cases where you have missed some of during your clinical examination, maybe imaging study, and sometimes imaging study will not help, and you can find it with your history and physical examination, because imaging studies are not helpful. And then other laboratory workup you already know, which includes blood test, including liver function test for the mets in the liver, in the case of advanced disease, complete blood count, urine electrolyte measurement, blood grouping testing, and cross-matching. In the case of it's important for the pre-operative, if you are planning to operate on this cancer, it's important. And then calcium level, as many as 4% of the patient with cancer in the head and neck may have elevated serum calcium levels. So this is poor prognostic indicator. For example, if the patient have oral cancer and they have elevated serum calcium levels, this is a poor prognostic indicator. So this guy is going to have advanced disease, and maybe the mortality rate is high. It means poor prognosis. Serum ferritin, alpha 1 antitrypsin, and then hepatoglobin levels, they will be increased, because now we are concerned with the liver, and liver, if the meds are going to the liver, because initially is asymptomatic, and when the patient comes, 30 to 80% of the patient of oral cavity, oral squamous cell carcinoma will have meds, and meds, one of the meds location is liver, and then these serum ferritin, alpha 1 antitrypsin, and hepatoglobin will be increased. And then we go for the chest radiography and endoscopy are variable procedures for excluding synchronous secondary primary tumors. For example, chest radiography may be indicated because of the lungs are most common site for metastasis and site for secondary primary carcinomas. So here we rule out liver as mets. Here we rule out if lungs have a secondary tumor primary to the oral cavity cancers, oral squamous cell carcinoma. And then CT scan or possibly other imaging techniques like MRI may be needed, or MRI or PET scan, PET scan, positron emission tomography, to see if those mets have gone to other places in the body. PET scan can tell about the metastasis. CT scan or possibly other imaging techniques such as PET scan may be needed to determine the degree of spread of some tumors or metastasis. Spread means metastasis here, particularly to exclude bone invasion or lymph node involvement. So for bone invasion, we can perform PET scan. Histological findings under microscopic examination of oral squamous cell carcinoma reveals, okay, important. If you perform the biopsy, we have performed biopsy and under microscope, under histopathological examination, what will we see? We will see some nests and islands of squamous cells. There will be clusters, nests and islands of squamous cells, because it's squamous cell carcinoma, which invades the underlying connective tissue. For example, basement membrane, it has invaded. That's why it is invasive, not carcinoma in situ anymore. It has invaded. In some of these tumor islands, there is aberrant keratinization, forming whorls of keratin within. You know, whorls like this. So you will find whorls like you find on your fingerprints, yeah, whorls of the islands, yeah. There will be tumor cells, yeah. The whorls will be there, and aberrant keratinization will be there, yeah. It's keratinized, is superficially keratinized. So this will be found under biopsy, especially histological finding was important, where we found nests and islands of squamous cell invading the underlying connective tissue. And in some of these tumor islands, there were aberrant keratinization of the cells, because they are squamous cell, they can keratinize and forming rolls of keratin within. So keratin molecule, protein, is forming rolls in them. The 8-step oral cancer screening, we have already studied. For example, we have to look, if we are self-examining or examining the patient, we have to look for cancers at mucosa, gingiva, upper lip, lower lip, hard palate, tonsillar area, soft palate, buccal mucosa, posterior gingiva, vestibule, anterior gingiva, mucosa, lateral border of tongue, and floor of mouth. And again, it's worth repeating that lateral border of tongue, buccal mucosa, hard palate, and floor of mouth are most common 4 sites for oral cancers. Oral cancer love it. And then how to check them out? Again, these are another picture. So now we go for the TNM staging. What is TNM staging? TNM staging means T for tumor,